This video reviews how we might analyze the anterior surface shape of the eye to determine the patient's potential for quality of acuity. It is also going to discuss the disease detection indices available in your Medmont software. Let's begin with this case. Is this an irregular eye? Is this a patient with a high potential for visual acuity? This patient has a with-the-rule-like cornea, but some asymmetry, so let's understand the powers within the pupil. When we put our cursor in the superior area of the pupil, we see around a 45 diopter radii of curvature, whereas when we go to the inferior curvature, we're about 46.5 diopters. That's a 1.5 diopter difference between the power in the superior pupil versus the inferior. Not extremely high, but some asymmetry that might contribute to a reduction in the quality of acuity. Can this patient achieve 6/15 vision? We might not expect that kind of quality acuity with an asymmetry like this on the anterior surface. We could look at the K readings and we see that this patient has a steeper cornea, but relatively normal astigmatism of 1.28 diopters. Now we might say that this patient is slightly irregular or asymmetric in terms of the power distribution across the eye, but is it really a diseased eye or is it just a droopy inferior displaced apex? What would tell you that this patient is a diseased cornea, a patient that we might want to consider sending off for corneal cross-linking? Well, on this one Medmont window, we have virtually everything we need. Let's begin by going to the axial map. The axial power map is the way to interpret the power distribution across the cornea, the kind of visual cues that we just discussed. Another reason to use the axial map is to understand the scale range of power, this distribution of curvature across the corneal surface. Start by selecting the axial power map, then go down to this button here and select Normalized Power. What Normalized does is it interprets this cornea in relationship to the full range of curvature that's presented. We see the flattest we can read is approximately 35, almost 36 diopters. The steepest the topographer can find on this cornea is 46.62 diopters. So this patient has approximately a 10 to 11 diopter distribution of power across the entire surface. Normal corneas fall within 10 diopters of scale range. So this patient is just above that threshold of normal versus abnormal. We might consider this a suspect eye for disease. Now there are other disease detection indices that are very specific. We can go over to the right-hand side of our attributes window. We notice these three boxes lit up in yellow, red, and green. The first, the IS value, or inferior versus superior index, takes the inferior hemisphere and averages all these numbers, then compares it to the superior hemisphere and averages all these numbers. The difference between the upper and lower hemisphere gives us an IS index. In this case, the inferior hemisphere of the cornea is 1.24 diopters steeper than the superior, and that's seen easily in this hot curvature that we see in the inferior cornea that really isn't in the superior cornea. And the width of this area of hot contour is certainly wider compared to the superior. So the IS value is indicating that this eye is suspect. It's not over the threshold of irregularity. If it were, then it would light up in red, but it's lit up in yellow, indicating suspect. The second index is your surface asymmetry, and that's looking at the oblique meridians and how close they are as a mirror to each other. is this side of the line a mirror of this side of the line? And then going to the opposing oblique meridian, is this side of the line a mirror of this side of the line? The smoother and more symmetric the eye, the closer the surface asymmetry index will be to 0. The higher the number, the more asymmetric it is. When your value is lit up in red, that's telling you the surface asymmetry is over the threshold of irregularity. Again, yellow would be suspect. The final index is the surface regularity index, and that is looking at how smooth the power distribution is within the pupil. How smooth is the central cornea? The higher the surface regularity, the more differential of power exists across that central cornea. The lower the surface regularity, the lower the power distribution. In this case, the surface regularity index is lit up in green, telling us that we have a normal distribution of power across that central cornea. Again, if it were lit up in yellow, that would say it was suspect, and red would say it's irregular. Another indices that's less commonly used is the eccentricity. Eccentricity is a measure of the change from the center of the cornea to the periphery. The higher this rate of change, the flatter the peripheral cornea is becoming. A normal rate of corneal flattening with the Medmont is approximately 0.65, and this patient has a slightly higher rate of flattening across the flat meridian of 0.8. This can also be an indication of disease. So with this one single Medmont window using the axial power interpretation, we have a lot of indices that help us to appreciate whether this is a normal eye. We can see that the distribution of power is slightly asymmetric. That might contribute to a slight lowering of the visual acuity potential for this patient. We can see the scale range is just above the threshold of abnormal, making this eye suspect for the earliest signs of disease or corneal thinning. The corneal shape is relatively normal, slightly steeper with normal corneal astigmatism. However, the eccentricity is a little above the norm of 0.65, and the disease detection indices are saying some are suspect, some are definitely irregular, and some are normal. So certainly this is a patient that we should be following a little more closely over time. Here's our second case. Is this an irregular cornea? Or is this a patient with a normal astigmatism that just happens to be severely inferiorly displaced? What tells us that this is an irregular cornea? Well, we can start by going to our axial power map, making sure that we're interpreting corneal power as opposed to corneal shape. And we notice there's a big distribution of power within this eye. We can click our cursor here, and we have approximately 43.5 diopters. When we click our cursor over here, we're at 58 diopters. So there is a massive distribution in power spread between these 2 points that are only within about 2 millimeters of each other. Clearly, the power distribution within this eye is well outside of the norm, and we would expect this patient to struggle with conventional glasses or contact lenses. Our spherocylinder refraction is unlikely to give this patient quality acuity. We're likely to need some type of specialty lens, most likely rigid lens optics. Now, what else could we look at? The scale range over here, using the normalized power, we have a 33 diopter flattest curvature up to a 59 diopter steepest curvature, or a 26 diopter distribution of power across this eye. Remember that normal corneas fall within approximately 10 diopters of scale range. So this patient is well past the threshold of irregularity. We could look at the K readings, and the flat K is a little toward the steeper side, but we notice that there's this massive corneal astigmatism of 11 diopters, completely irregular or atypical. We could look at the eccentricity and remember that normal E is about 0.65, and this patient is indicating to have 1.21 on the flat and 1.15 on the steep. Off the charts eccentricity that's describing that this cornea changes at a very radical rate from the steepest in the center to the flattest in the periphery. There is this significant change in curvature. This is why keratoconic patients require specialty contact lenses. They would need a lens that may have a very steep central optic zone, but an incredibly flat and aspheric peripheral curve system to be able to manage this high rate of change between the center and the peripheral cornea. Our principal disease detection indices are saying this is an abnormal eye. The Medmont software helps to make your assessment of the potential for visual acuity and possible signs of disease a very fast and efficient diagnosis. If you have any questions or for more information, contact your Medmont distributor.